We've changed the order of talks just a little. I now request Dr. Sharmili Sinha ma'am to kindly come and deliver her lecture. And, personalized glycemic control.
Very good afternoon to all the esteemed delegates and faculties and senior members here. And my heartfelt thanks goes to Dr. Mohan Maharaj and team Reflect 2021 for giving me this opportunity. And after this very highly scientific micro and nano level talk on personalized sepsis treatment, I have been asked about to talk about personalized glycemic control, and I also have the honor of being the first physical speaker for this Reflect 2021. So with that pleasure, and I think post lunch all of us have good sugar levels, or at least some little higher sugar levels. I'm glad to talk about this topic on personalized glycemic control. So what is new about sugar in critical care? For at least more than 2 decades, we have been talking about good or optimum sugar control in critically ill patients in ICU for best of outcomes of all fronts. So today the learning objectives of this talk will be and this headings. So now it is quite well established and evidence-based facts among all in the community, in the medical fraternity, that hypoglycemia or blood glucose variability is associated with increased ICU mortality, and for that matter all the secondary ICU parameters, be it ICU stay or ventilation or other organ dysfunction outcomes. But now it is increasingly getting more evidence-based fact that glycemic control, which is present at the time of ICU admission for the patient, has also got an impact on the sugar control or the target sugar control that we try to achieve during the treatment of the patient in the intensive care unit. And ICU mortality, of course, as an outcome of that. So this ICU glycemic control at the time of admission is an independent factor which is associated, and there is also now emerging evidence that this survival benefit is more pronounced in patients who do not have diabetes mellitus at the time of admissions. They might be having stress-induced hypoglycemia or maybe dysglycemia for a variety of reasons, or the disease etiology for which they have been admitted to the intensive care unit. So I would request you to take note of 2 facts that some category of patients, when they come to ICU with any kind of critical illness, they might be having pre-existing diabetes mellitus, and many do not have also pre-existing diabetes mellitus. So they might develop stress-induced hypoglycemia or just dysregulate of the glycemic control due to a variety of reasons, and hence we have to personalize or target our glycemic control strategy according to this based on this property. So this is a quick depiction of stress-related hypoglycemia. I am not going to the details of this. I think there is a lot of cytokines, inflammatory mediators and hormone release happens during critical illness, which give rise to increased level of blood sugars, which is quite brittle during the day and throughout the stay in the intensive care unit. Now if you look at, we talk about the history of literature about sugar control in ICU. This is the first, we have a pointer. So this is the study, I think all of us would have gone through this during our training days. This is the classic or the landmark trial by Vandenberg in surgical intensive care unit, where he looked at around 1500 patients and aimed for tight sugar control, and he aimed to keep the sugar less than or between 80 to 110 milligram percent. And he claimed that it reduced mortality from 8% to 4.6%. And it was very widely advocated during that period that we should go for tight sugar control in the ICUs. And not only intensive care unit mortality, but also the in-hospital mortality, the need for ventilation, ICU stays, and need for renal replacement therapy, everything was substantially reduced. So there was a lot of advocacy and emphasis on tight sugar control in those days. Okay, it's fine. Okay. But this was really difficult to achieve, in most difficult to be replicated in most of the units, not only in India, also in across Europe or different countries like US or Australia also. Because to achieve that tight control of 80 to 110 milligram percent, you need to have a 1-to-1 ratio care for these patients and intense monitoring in terms of number of sugar tests and also following those patients, which is not a practical scenario. So years after, in 2009, the study of NICE sugar control study, which was conducted in many, it was a multi-center trial, and they looked at that tight sugar control versus a liberal control, where they aim to keep sugar control within 110, between 80 to 110 milligram per cent in one group of patients, and the other group they tend to give the random sugar less than 180 milligram per cent. And it was found that the mortality was better in the liberal sugar control group. So thereafter, actually, now evidence has changed, and these were the things which were actually being practiced for decades together. In the year 2011, AG et al. Actually looked at HbA1c to assess the effect of acute and chronic glycemic status in patients. Before that, actually, there was not much emphasis put on the glycemic status at the time of admissions to intensive care unit. And many small observation studies also point that mortality increases with rising blood glucose in patients who have low HbA1c at the time of admissions, but not in general for whom might be having a poor glycemic status at the time of admissions. So mortality decreases more for this patient, decreases for patients with poor glycemic control at the time of admissions. There are many other kind of parameters that we have looked at for these patients, like something called stress hypoglycemic ratio. What is it? It is the admission glucose divided by the HbA1c at the time of admissions. And also something, there's another term called glycemic gap. It is decided by blood glucose at the time of ICU admission minus the mean glycemic value during the ICU stay. So considering all this fact and the gap in knowledge and understanding about how to manage different kind of patients who get admitted to ICU, this was a retrospective study which was done by Prinsley et al. In US, and it was actually looked at a huge data set of patients spanning over around 8 years, from October 2011 to 2019. 5,500 patients were looked at. These are the patients, and this is a center I would like to tell you that they had much focus on glycemic control. They had a very good and skilled training intensive care unit teams, and all these patients had at least 4 glucose readings and had HbA1c done at the time of admissions or within the 3 months of ICU admissions. So these patients were divided into again 2 groups, before 2014 and after 2014, because in that particular center, the glycemic strategy of the protocol was changed after October 2014. In their unit, they used to look at the blood glucose level at least 3 hourly, and if the patient required IV insulin infusions, it was done hourly basis. They looked at usually arterial or capillary blood glucose or venous sample according to the patient profile. So this is the clinical characteristics. Accordingly, you can see they have really looked at this HbA1c and divided into different groups. So patient who had low HbA1c less than 6.5 were put into one group. This is the intermediate group which they call pre-diabetic group, and this is the poor glycemic control group who had HbA1c more than 8 gram per cent. So this is an interesting figure which depicts. So now I have told you that they have divided into 3 groups. So in the group where HbA1c was less than 6.5 gram per cent, so they were the good glycemic control or non-diabetics before ICU admissions. There you see mortality is significantly associated with rising blood sugar. There is a very good or direct correlation with the rising blood sugar in this particular group. Now come to the pre-diabetic group, it is raised but not as high as the pre-diabetic, the stable patients or who had got less HbA1c. Now come to this poorly glycemic control group where actually most of our attention is focused. Here with the rising blood sugar actually mortality is less, or rather we can say does not get affected. So this is some contrast finding or observation that has changed the perspective towards management of glycemic control in intensive care unit, especially for patients who had poor glycemic control at the time of admissions. And this is something where we have been recurrent to think about personalized glycemic control for patients. So one size cannot fit all. This is a bit more dissection of the data that they had presented. As I said, they had divided their 5,500 patients into 2 groups depending on the time before 2014 and after 2014, because there was a change in policy in glycemic control in that center, and they had followed this SCCM, Society of Critical Care Medicine guidelines. So if you see, again these 3 groups I would say, in the group where HbA1c was less than 6.5, pre and post era, like before and after 2014, mortality is almost remains same. So mortality remains high in this group if the sugar levels are high, rising. In the patient who had pre-diabetic status between HbA1c between 6.5 to 7.49, it remains in the intermediate group. But again, in the patient who had poor glycemic control, that is HbA1c more than 8 gram percent, you see actually mortality tends to be significantly low. So that doesn't mean that higher sugar means nil mortality, but it would say that it does not directly affect the mortality. So what are the key points from this Princely study? Because this has been a good study which was published in 2020, and some of the very important and thought-provoking observations have been made. So first is the strong correlation between ICU admission, blood glucose, that is the blood glucose at ICU admissions, and chronic glycemic status, which is best assessed among the available tool being the HbA1c. And there is increased mortality for patients who have HbA1c less than 6.5 on admissions. That means their sugar control has been good before ICU admissions. But if they are having higher blood glucose during ICU admissions, their mortality is going to be high. And it's an independent predictive factor. Now, less mortality for patients who have H1AC more than 8 gram percent. That means they have already have poor glycemic status, and if they are having even for different reasons a high blood glucose level, it's not going to significantly affect their mortality outcome. Hypoglycemia was associated with high risk of mortality in all groups of patients, be it less or good or bad glycemic status before or after admissions. And patients who were in the intermediate group, that is in the pre-diabetic status, they had similar characteristics with glucose metrics and IC mortality as diabetics. Patient who has increased H1AC was also associated with higher glucose variability. The other term that mostly the endocrinologists use is the brittle sugar, we call it, for patients who are on the nasogastric feed, etc. They have greater glucose variability, and there is increased incidence of hypoglycemia and IC mortality. This we have already discussed. So what about hypoglycemia incidence during glucose control? A lot of observations have been made in different studies. Summatively, I would say less hypoglycemia is seen in patients where we are using a liberal status, say 80 to 100 milligram percent, because your range is high. I mean the spectrum is high, and it's mostly in the second era after the strategy or the policy was revised after 2014. Increased blood glucose was also found in patients who had an hemoglobin HbA1c more than 7% due to higher targets. More variability is associated with increased mortality, especially in patients who have got stable glycemic status. Hence, it comes to that intense monitoring is overall required to avoid hypoglycemic events. That means more, nursing staffs, personal strength in your unit. What is the relation of the pre-admission and glucose variability? Now, chronic hyperglycemia actually gives kind of better tolerance to acute hypoglycemia in diabetes. If they are developing hypoglycemia for whatever reasons, they tend to tolerate it better. And many of times, actually, most of us patients also, like patients who have got CKD, come with sepsis, they are on renal replacement therapies. The sugar actually jumps all over the place during a day. And in my clinical experience, I have not seen them showing classical hypoglycemic symptoms like dizziness, sweating, or getting unconscious during their period. And this time, many times, moguls are mild, and this is the reason that they do not, they tolerate this acute hypoglycemia better than non-diabetics. And pre-diabetics for somehow are not tolerant to this acute hypoglycemic events. So benefit of optimal sugar control in ICU is more in non-diabetics and pre-diabetics. That is one of the best centers that has been already focused on this sugar control, and staff is highly trained and skilled. So for them also they had issues. So imagine if you're extrapolating this to a continent like India with all our limitations, it is difficult to replicate these results. But the motto remains to be alert and put attention on glycemic control and continuously training your staff and junior doctors to take note of this factor. And other aspect of our practices is about non-uniformity of glycemic control protocols across various ICUs. As one of the guests, eminent guest was mentioning that what we are discussing here should be if you go to the med sector, be it in the corporate sector or in the public sector. But unfortunately, there is a lot of non-uniformity and wide variation in the approach of sugar control in our ICUs. And semi-open and open ICU nature is also another promoting factor for implementing implementing this evidence-based practice for glycemic control in ICUs, because best and ideal ICU are across the world. We have to proceed in Australia and few of the centers in the US or parts of Europe. But in India, most of the ICUs are actually wide open ICUs or semi-open ICUs, where both the intensivist and the primary admitting teams come and play with the patient's medications. So I would say, like, if your primary physician happens to be a physician or a medicine specialist, most of the times the insulin prescriptions get hampered by either the peak sometimes during the day, and so there is confusion amongst regarding how to use the insulin regimen that has been prescribed. So this is one factor which actually I believe greatly prohibits or hampers ICU glycemic control in ICUs. There is more indication for using sliding scale insulin for some reason in our ICU state. Those sliding scale actually for controlling sugars in patients who are critical is widely ineffective. So we have to use a combination of both short-acting and long-acting insulin in these patients for best of results. Again, reliability of improving the findings is also a factor, because many times if the machine itself is faulty, it may not give you the best of results. And also for patients who are in shock, multi-organ support, the peripheral perfusion is compromised. So at that stage, if we are pricking your fingertip to get a sugar reading, it may not give you the right reading. And many times we see that patients who might be wide awake, comfortable, and you are taking a sugar from the fingertip, while they are on high dose vasopressors, it would be surprisingly low, but the patient clinically will be fine. So actually that times we modify our threshold for treating hypoglycemia to as low as 60 or 70 milligram percent also. There is less awareness among the treating staff, and cost is always a factor there. So what do we do in our unit? We usually target for a liberal range of from 110 to 180 milligram percent, 4 to 6 hourly if sugar levels tend to fluctuate. But if 200 for two consecutive figures, then the patient is usually started on IV insulin infusions. Then usually first few hours, 4 to 6 hours, we do hourly sugars and then change to 2 hourly sugar checks. Long-acting and short-acting agents are commonly used in patients who are established diabetics, or after a couple of days when you know that they are requiring insulin infusions, then you can extrapolate it and make it a scale. Insulin doses, because many times, suppose the early morning sugar will be sometimes 90, 100, 105, and if your staff is not well trained, they will just hold the morning dose of insulin, be it a long-acting insulin or a short-acting insulin, and not surprisingly the pre-lunch sugar will be hitting 300. So do not try to hold the prescribed dose of insulin unless the patient is actually manifesting signs of hypoglycemia. And we always ready to treat the etiology, address the etiology if it is active sepsis. Many patients might be having upper hypothyroidism or hypothyroidism, which may not be known at the time when the patient is admitted to ICU. And if you are having a brittle sugar which is fluctuating all over the place, many times actually you just send a thyroid function test and you will not be surprised if you discover a deranged thyroid function test. Many times actually we use this, especially in patients with brain trauma, neurotrauma patients, because 40% of admissions in our ICU are mostly neurotrauma cases. And steroid is another factor. Many patients like rheumatoid arthritis, if they are having immune disorders, they might be on steroids, and even post-transplant patients. And not to forget the septic shock patients. When we prescribe this sepsis dose of steroids, while the patient starts improving, we actually forget to stop steroids. So these are the ones which also should be taken note during daily rounds. Hypoglycemia should be treated only if symptomatic. As I said, because just the finger-prick glucose may not manifest the real sugar value. So if a patient is hypoglycemic, like showing sweating, dizziness, you're not feeling well, it should be treated. And go for arterial and venous blood glucose settings in patients with peripheral hypoperfusion, because if they are having high doses of noradrenaline or vasopressin, the perfusion will be anyway compromised. So that capillary blood is not going to give you the ultimate of the real sugar. But of course, if you are handling your arterial line or venous line more frequently by the staff, there is risk of infections, then we have to be cautious. And should not aim for rapid control of sugars in poorly controlled diabetic patients. If they are coming with diabetic ketoacidosis or other hypoglycemic events, it has to be achieved over a period of time. So summarizing, should we change our practice based on what we just discussed? the fact that now we should be at least aware or cautious to look at patients who are getting admitted to ICU, what has been their glycemic status and admissions. So my answer would be broadly no, but of course I will be more cautious, at least be alert about knowing their glycemic status before the admissions and would try to achieve the goals accordingly. But there is no second thought that optimum sugar control is essential for best of any outcome for a patient who is admitted to ICU, be it your ventilation, sepsis control, or liberation from any other organ support. So one size will definitely not fit all. You have to customize according to the patient's profile. And emerging evidence do point that there are different strategies should be applied for pre-diabetics or diabetics with good glycemic control, and slightly tighter control like 80 to 140 mg% may be more appropriate for this population. But patients who have got poorly controlled diabetes, we can be liberal with little higher levels up to maybe 180 or 200 mg%. More frequency of blood glucose monitoring should be advised. I know most of the corporate hospitals, at least I think we are doing glucose monitoring more accurately or regularly. But I think public setups, at least this practice also should come into place. And I would like to just remind ourselves about this permissive practices for, like, as we speak for permissive hypoxia, permissive hypercarbia in ARDS ventilation, or even permissive hypoperfusion or hypotension in septic hypotensive patients. Also, I would say that we should be having an open mind to go for permissive hypoglycemia or permissive hyperglycemia at times, depending on the pre-existing glycemic status of these patients. And need for H1AC test for all patients on admission, I think it's a good practice and it's not very expensive, should be encouraged. And avoid large blood glucose variability. It's like if your sugar is jumping all over the place, better try to understand there is some factor which is underlying and unaddressed and get over it. We have to empower our nurses to address this factor because they are the ones who are ultimately at the bedside checking your blood sugars, and something called glucose control stewardship should be also advocated in ICUs. The stewardship list is getting long and long, so to add to that, glucose control stewardship. And future trials are always there. It can be based on this, I think, retrospective study that Prince et al. Has done. One future trial regarding these two particular groups who have a good glycemic control or bad glycemic control at the time of ICU admissions would give us more enlightenment. Thank you very much.
Thank you, Dr. Sharmili Sinha. And I think you being the first physical present at the same time, you have traveled in the train for more than 8 hours and come from Bhubaneswar again going back immediately to understand your question. Thank you very much for your time. And regarding physicians will tell much tell about glucose and everything.
Thank you very much. That's a very, very good talk. I hope everybody takes those points. The summary is beautifully summarized. That's actually what we have to practice to get proper diabetes control in critical care people. And moreover, empowering the nurses is the more important thing. They should be the ones who should be given a little bit more freedom in managing it. And another important point you mentioned is that a little bit lesser glycemic sugar level, the nurses usually miss the dose. They usually skip the dose in the morning whenever they see glucose level being 90 or 100. We have to emphasize that that's not what we want. We want the sugar level to be around that level, and if you miss the dose, it's going to go up to 200 to 50 in the afternoon, that you check again. So that is something we need to educate our nurses on. Thank you very much.
Thank you.